Welcome speakers and participants, and thank you for joining this conference, a joint event organized by left parties in Southeast Asia and also Australia. Our organizers are Parti Socialist Malaysia, Socialist Workers Thailand, Partido Lakas ng Masa in Philippines, Socialist Alliance Australia, Partai Rakyat Pekerja, Working People Party in Indonesia, and Kesatuan Perjuangan Rakyat KPR Indonesia. I'm Fahmi Panimbang. I will be the moderator of this session. Before we start, I'd like to briefly go through some housekeeping rules. First, all participants are requested to respect difference in views and opinion. Second, please post questions in a short and specific to the respective panel for their views. Third, question and answer or Q&A is not for debates, but for asking questions only. Fourth, we will not tolerate any derogatory remarks, sexist or vulgar postings in the chat, and the organizers have a right to remove such participants if they are found to do so. Comrades, we have simultaneous translations in Chinese, Malay, Bahasa Indonesia, and also Thai. For this translation, you will see this in the bottom right at the corner on the screen on the translations button. You can select the language. Please mute your microphone when you are not speaking. For participants, if you would prefer to write a questions or comments, please use the chat box, which you can use throughout the session. This session's topic is building an equitable healthcare system for the 21st century. Indeed, it is an important topic given the fact that we are still struggling with COVID-19 pandemic. The pandemic has disclosed how broken is our healthcare system under capitalism. In the near future, I think healthcare issue will still dominated by vaccinating the world against COVID-19, and it will remain a core priority. However, we are aware that healthcare system will also need to start handling a backlog of non-COVID health problems. Let us not forget that we are still fighting against endemic diseases in many parts of the world, including in Asia. We still have tuberculosis, malaria, HIV, etc., and they are equally important. At the same time, we have been witnessing hundreds of thousands of healthcare workers have died during this pandemic. What went wrong? What can be done to solve the problem? What is socialist perspective on building an equitable healthcare system? These are the questions to be addressed in these discussions. We are very much privileged to have three competent speakers to discuss about the topic. I will now introduce our speakers. The first speaker, Maria Fatima Villena, or Jofti. Jofti is a freelance development worker for several civil society organizations in the Philippines. She provides technical writing and consultancy to several health projects, including water and sanitation, healthy eating or agriculture, road safety, health budgeting, etc. At the same time, she also organized freelance writers to advance their rights as workers by forming a group called the Freelance Writers Guild of the Philippines, together with other conveners, and now the organization is now registered as workers associations in the in the Philippines. The second speaker, Dr. Chi Henglen. Dr. Chi works in the field of health and healthcare. She was part of the group of academics, researchers, activists, and advocates who founded Citizens Health Initiative in Malaysia in 1998. This group worked for equitable, accessible, and sustainable healthcare of quality. Dr. Chi previously held academic positions in several universities, but now she has retired but still continue with her academic writing and advocacy work. Our last speaker, Wasi Gede. Gede is Executive Director of Research Institute called Inggris Pena. Previously, he was a lecturer and researcher at the Faculty of Social and Political Science at Universitas Indonesia from 1998 to 2016. Gede fields of interest is the areas of political economy, labor studies, social conflict, and social philosophy. He currently works in research and advocacy program called Mind the Gap, Strategies for Improved Access to Remedy, jointly with research institutes from 8 countries in Asia, Africa, Europe, and Latin America. Comrades, let us now welcome the first speaker, Jofti from the Philippines. Jofti, the space is yours.
Hello, good morning, good afternoon, and good evening, comrades. May I share first my screen?
Sure.
All right. So good afternoon, comrades. Again, I'm Jofti Villena from the Philippines, and I'm honored to be participating in the Socialism 2021 conference, which is in the same table as our longtime and esteemed socialist revolutionaries across the region and globally. So I will be sharing with you building an equitable healthcare system for the 21st century, and that I will be sharing the elements of the healthcare system, which I have gathered through years of engagement in the health advocacy and formal study, but of course with a dream of socialism in mind. Because as of now, we only have Cuba as a working model, and not all have the same context as this island nation. But we always improve on it, guided by the principles of Marx, Engels, and Lenin.
Jofti,
Yes?
sorry, you have 20 minutes, and please speak slower.
Okay.
Help the interpreter.
Okay.
Thank you.
All right. So again, I will be discussing several elements of the socialist healthcare, envisioning both an ideal and real health system that cares for all. Okay, so I would like to begin my presentation with a proposal of a new call for the 21st century healthcare system, which is a holistic health for all. The previous calls in the previous era was primary healthcare, the Alma Ata Declaration of 1978, which is an international conference on primary healthcare for all, for urgent action by all governments, all health and development workers, and the world community to protect and promote the health of all the people of the world by the year 2000. We have the call of universal health care, as known to be in the international level as universal health coverage for all. But we do not use universal health coverage, but we use universal health care. So if we are to build a socialist healthcare system, these are the elements of which I would like to put forward with us. the commons, the public, collective, and solidarity type of healthcare system that we all know through the model of Cuba. So first and foremost, why I model Cuba after it? It's because Cuba is well known to share its medical brigades. It is now in different parts of the region, the Caribbean, the Latin America, Africa, Europe, and the Middle East. So they share these medical brigades because they believe in solidarity with all of the peoples of the world. And President Lula da Silva, former president of Brazil, said, while rich countries export soldiers and drop bombs on poor communities, Cuba, by sending doctors all over the world, exports life, love, and health. In fact, Cuba also exports national liberations movements. Fidel Castro in that time helped different African countries in its fight against the apartheid. And because of this, Cuba has been able to develop their own vaccines for humanity. So its idea is really to share their health system, their know-how to humanity without cost. And in fact, Dr. Halfdan Mahler, a former director of the WHO in 2000 said, there's no other country that has been as consistent in taking measures towards achieving the goal of health for all as Cuba. And with this, Cuba's achievement was really in different areas, like in the women's sector, there are 53.2% of MPs that are women, the second highest in the world. Infant mortality rate of 4:1,000, lower than the US. Over 4 million site-saving eye operations worldwide since 2004. And 31,000 students from 103 countries trained by Cuba's Latin American School of Medicine since 1998. In fact, we have 2 scholars in Cuba, Filipino scholars at the moment, under the help of our own Friendship Association here in the Philippines. So next, equity and universal design. These are 2 important elements in a socialist healthcare. Why? Let me draw your attention to this video that I will be showing to explain further what do I mean by a healthcare system that allows for or promotes universal design.
Like the size of shoes I wear?
I'm afraid you must be mistaken, sir. All of our shoes are the same size. Here, let me get a different shoe.
Is it going to be the same size as the first pair?
Well, of course.
This isn't going to work. I think I'm going to go.
Wait, we got a new shipment coming in. Oh well.
We wouldn't go to a shoe store that only sold one size of shoe. So why do we try to teach students only one way? Universal design for learning is about teaching all students, not just the average students. To do this, we need to represent information in multiple ways, give students opportunities to choose how to express themselves and show us what they've learned, and make the learning engaging and relevant for everyone. We need to listen to our students' needs, cater our teaching styles to their learning styles, and make sure they stay engaged. By doing so, we'll create a better learning experience for everyone.
Have you ever encountered a situation like this? Your hands are full of grocery bags. You get to a door. You realize there's no way you can open that doorknob without putting the stuff down. In that case, it's possible you've encountered a round doorknob. For many people, encountering a door without an easily operable lever is usually just a minor inconvenience. But for people with manual dexterity limitations, hand injuries, and other related disabilities, a round doorknob may prevent them from being able to go through that door. If that door had a lever-style handle, it could be operable with a closed fist or even an elbow, making it much more accessible to people with or without disabilities. Similarly, even though power door operators are often designed for people with disabilities, the reality is that they make going through a door easier for all kinds of people, including people using wheelchairs, crutches, and walkers, people carrying a handful of shopping bags, parents with strollers, and delivery people carrying boxes or pushing trolleys. I'm an interior designer, and I often think about how everyday environments could be improved with good design, from overall circulation flows throughout spaces to details like door hardware. And a part of good design is having the awareness and consideration for people of different abilities. While many accessible design components may have initially been designed with disabilities in mind, the vast majority of accessible improvements to products, fixtures, and environments actually end up providing better access for everyone. Automatic toilet flushes, faucets, and soap dispensers are easier to use for people who cannot reach or cannot operate levers, buttons, and valves, but it also makes using a washroom more sanitary and more convenient for most people. Visually contrasting flooring transitions, tactile warning strips, and cane-detectable barriers help many people, whether they have a visual impairment or not, to see and detect oncoming hazards more easily. Over the last few decades, some designers have also adopted the principles of universal design, which is a design approach that considers many different human factors, including abilities, age, genders, and cultural backgrounds. Universal design reframes the approach to how we think about people with disabilities, where their needs are not seen as special circumstances, but as a part of many different human factors that require consideration. For instance, drinking fountains, lavatories, and service counters with high and low surfaces, or desks and tables where the heights are adjustable, are not only designed for the use of wheelchair users, but also for children, older adults, people of different heights, and people with different usage preferences. Simple, easily navigable wayfinding with visual and tactile signage help people with visual and auditory impairments, but can also improve the experiences of people who speak different languages and people with cognitive disabilities. Universal toilet rooms can accommodate not only wheelchair users, but also individuals traveling with caregivers of the same or opposite gender, families with children, as well as people who prefer to use non-gendered washrooms. Often the concept of providing accommodations to disabled people is misunderstood as making disabled people dependent on society to help them, when in fact accommodating disabilities is pretty much the opposite of that. While some disabled people do require caretakers or guide animals to help them with their day-to-day life, the goal of accessible design is actually to provide independence for people with disabilities. If we provide ways for people to independently open doors, go up levels, use the toilet, get around safely, obtain services, and find information, basically go about their day-to-day life like most other people, then technically they're not disabled anymore. It's important to realize that traditionally we have built our environments to exclude certain people. Disabilities are not inherently possessed by the individual. They're shaped by the barriers we have put up. While it's obviously not practical to immediately rebuild everything, there are still things we can do and steps we can take to remove these barriers. Some may argue that designing and building accessible products and environments can be costly. While that may be true in some circumstances, when it comes to building new spaces and creating new products, there is often not a cost difference to implementing accessible features. Choosing a more visually contrasting color at a change in floor level usually costs nothing as long as the product is the same, and installing one type of door lever over another will result in minimal price differences, if any. But of course, there are still costs to some accessible features, and the retrofitting of existing non-accessible spaces could have a high initial cost. However, in many cases, it is arguably more economically detrimental to ignore accessibility. According According to the World Health Organization, around 15% of the world's population live with disabilities, a percentage that's expected to rise in most developed nations due to the increase in the older adult populations. Communities and businesses all benefit from the participation of people with disabilities, as consumers as well as being productive members of the workforce. Even in private homes, inaccessible design will also directly and indirectly cost individuals money, such as in the loss of productivity, as well as in the cost of caretakers or people taking time off work to care for disabled family members. By building spaces that accommodate people with disabilities, we can provide them with economic empowerment and independence. And in most cases, we will also improve the quality of life for just about everybody. If you look at it this way, accessible design may just be one of the most morally and fiscally responsible things we can do. So what do you think? What are some design improvements that you think would benefit accessibility and usability in your life, whether it's at home, work, school, or a public space? Leave your thoughts in the comments below. Thanks for watching. This video is a part of a series.
Okay, so I shared with you those two videos just to prove a point that our personal lives are affected by the simplest things and choices we have, and how our surroundings affect which affects others, and sometimes it excludes others. So another element of a socialist healthcare is that we need to be integrated, interconnected, interdisciplinary towards transdisciplinary, multisectoral, and whole of society. So what does that mean? For example, in this photo here, we see that the urgent general practices or services, the specialist care treatment, and the restorative support or rehabilitative care treatment is in one community, wherein all of the peoples can easily access them, and that spaces are designed according to how each one of us live a healthy life. So that is what we mean by integrated. And also, being transdisciplinary or interdisciplinary means that we put also health in all policies, in all, for example, in family support, recreation and open spaces, public transit, and active transportation. Unlike now, we design our health system according to disease-based or organ-based services and care. And also, we need to know that only 20% of these medical aspects goes to our health system. And the other things like behavior, socioeconomic factors are not being included in our understanding or in the services provided by our governments. And another thing is that sometimes our choices and our cultures are also being thwarted or disregarded by government because of their insistence that evidence-based is the only way to go. But how about the traditional and complementary healing systems that has been already in our countries for generations and generations? In fact, Che Guevara said on his speech in 1960 on revolutionary medicine, said that often we need to change our concepts, not only the general concepts, the social or philosophical ones, but also sometimes our medical concepts, because it is not always the way to go. Another element that I would like to point to you as part of our socialist healthcare is the participatory and democratic elements. It is best to put the health in the hands of the people, they say before, but as I say it, health in the hands of the masses, because we need to be very clear with our class line here. Because not only that the masses are the ones really bearing the brunt of all the services, the policies that are being proposed by capitalist government, they are also the ones, really creating wealth because these are mostly our workers. So for me, these are the elements that I think would be help us imagine socialism. And this is the road ahead in an unfinished map. So we see that there is one road, and that what we wanted is for our people to be cared for in every step of in every stages of their lives, including in their living, moving, playing, learning, and working conditions. So as socialists of the 21st century, we wanted, or I invite every one of us activists to allow, to let socialism be our way to go, way forward, because it allows us to dream and do the impossible beyond the current world standards. It is the time to go for it. Thank you very much, and good day to everyone.
Thank you, Jofti, just in time. Thank you for being punctual. Indeed, there are lessons learned from Cuba as a model, as also have been explored by Jofti. Now we move to the second speaker. Second speaker, Dr. Chi. Pardon me if I'm calling you wrongly. Dr. Chi, the space is yours. You are still muted.
Sorry, yeah. Okay, thank you very much, Fahmi. And thank you to the organizers for having me here. My talk today is addresses the title of the panel, Building an Equitable Healthcare System for the 21st Century. And I will be presenting the Malaysian case. Now, my presentation is going to be in two parts. In the first part, I just want to discuss universal health coverage or universal health care. The two terms are often used interchangeably, and it is important to address this because this is the current agenda in international health policy now, and it is also adopted by many countries in their national health policies. So after this, universal health coverage then will provide a point of reference for the second part of my talk, where I will present the Malaysian context. In the Malaysian context, I will also present two basic points, two major points. Number one, first, I will argue that we need to retain our current system of taxation-based healthcare financing. So the first part is on healthcare financing. And then the second point that I will be arguing for is that we also have to maintain and insist that government strengthen governmental or public provisioning of healthcare services. So not just financing, but also provision is important to be in the public domain. All right, now I start with my first part, which is universal health coverage. Now, universal health coverage is sometimes referred to as universal health care and sometimes referred to as universal coverage, but they are referring to the same thing. They're referring to the same thing because in 2005, universal health coverage, UHC, I shall just abbreviate it and say UHC, was adopted by in a World Health Assembly resolution. So pretty much, you know, the majority of countries, right, in the world, in the World Health Assembly. And then 10 years later, in 2015, universal health coverage was incorporated as a target in the Sustainable Development Goals, or the SDGs. So the SDGs, I'm sure you all know, are targets that have been adopted by United Nations to be achieved by countries by the year 2030. So like it or not, it's in the real world, okay? So we have to deal with it. So what is this UHC and how will it lead us to an equitable healthcare system? Now, on the WHO website, universal healthcare or UHC is defined as meaning that all people have access to the health services that they need, and that these health services should be of sufficient quality to be effective, while also ensuring that the use of these services does not expose the user to financial hardship. So this definition of UHC embodies three related aspects. Aspect number one is equity in access to health services. Everyone who needs services should be able to get them, okay? Number two is quality of health services. It has to be effective. No point getting services that are not effective, correct? Okay. And third, which is seems to be reiterated most of all, is that people should be protected against financial risk. That means to say the cost of using these services should not put people at the risk of financial harm. Okay, it doesn't mean it's free of charge, but it just means that using it doesn't put you at the risk of financial harm. Okay, what's the significance of UHC? Here, I just want to raise 3 points. First, we must note that UHC represents a shift from the previous framework of primary health care.
All recording in progress.
Now, PHC was laid out as a strategy that countries should adopt to achieve health for all in the Declaration of Amata in 1978. So that was the health policy for over 2 decades in the 60s, 70s, and even into the 80s. So UHC represents a shift. What is this shift? And how is it different from PHC? UHC emphasizes healthcare financing. It focuses on coverage, risk, and protection from financial hardship. Whereas earlier, PHC emphasized comprehensive healthcare, meaning that equal emphasis on all various aspects of healthcare, from provisioning to financing to preventive, promotive, rehabilitative, as well as palliative. Okay, the shift, therefore, is from comprehensive and integrated healthcare provisioning to healthcare financing. That's number one. Number two, the second point. Now, with the emphasis on healthcare financing, UHC advocates that this financing should be pooled, meaning it can be anything. It can be taxation-based, it can be social health insurance, it can even be private health insurance, so long as private health insurance is mandated. That means to say there's a law that says that everybody must get private health insurance, okay? So the UHC model in this sense does not prescribe the type of healthcare financing system for a country, only the principle that it must have a method of prepayment of financial contributions where risk can be shared across the population, and that people will be protected from financial impoverishment in the event of catastrophic illness. So in other words, some universal healthcare systems may be government funded, but others may be based on the requirement that citizens purchase private health insurance. So for example, in the US, the Affordable Care Act that was passed in 2010 is an attempt to build universal healthcare based on a mandated health insurance system. That means to say there is a mandate that everybody has to buy private health insurance. Okay, what's the third point? The third point is that it is important to note that UHC does not propose a unified system of public provision. It is in fact based on the premise that healthcare provisioning will in most cases be a mixed public and private system. So since UHC emphasizes the need to secure pooled financing funds for healthcare on the one hand, while on the other, it presumes that health services will be provided by
Recording in progress.
public and private sectors. It is therefore based on a notion or a concept of a provider-purchaser split. Financing and provisioning, conceptually at least, are separated. And the primary role of government here is to organize the availability of funds, which are then made available for both private and public healthcare providers. Okay, so this is at the conceptual level and at the policy level. Okay, what happens when it is transferred and implemented in a particular country? So let me use the Malaysian context as an example. Now, first, before I go into my explain my two points, let me explain what is the Malaysian context. Now, if you Google Malaysian public healthcare system, you will see that there are many writings, even on the WHO website, that would claim that Malaysia has already achieved universal healthcare or universal health coverage (UHC). And to a large extent, I would agree that this is true. For example, public health services are practically free of charge or subject to a nominal charge only for citizens at the point of utilization. And then we also have public health clinics and hospitals which are widely distributed, although there are still disparities between rural and urban areas. However, despite this, there are serious weaknesses in the public healthcare system that were already apparent even before the COVID-19 pandemic struck. Let me just explain three main problems. First is the problem of underfunding, leading to congested public healthcare facilities and long waiting lists. Number two, we find a big problem of undiagnosed problems, especially NCDs or non-communicable diseases like diabetes, hypertension, and even obesity, you can consider as a prelude to disease, are at the community level that are not picked up in the early stages by our primary healthcare system, by our primary care services. Okay, so these cases that are in the community that are not being picked up by our primary care services will end up being treated in the hospitals at the later stages, when treatment becomes more difficult and more expensive. Okay, so this is the second problem that was already there before COVID-19. Number three, the third problem and the most major and intractable problem of our public healthcare system is the perennial brain drain and a shortage of experienced and skilled medical personnel, because medical specialists leave continuously for the private sector, resulting in there being more medical specialists in the private sector, even though majority, more than 70% of hospital utilization is in the public sector. So you end up with specialists or doctors in the public sector being overworked and private sector, being having what I would call actually a surplus of specialists. Now, given that these context of these problems, what has been in the discourse? What has been the health discourse in Malaysia in the last few decades? Okay, since the 90s. Okay, what have people been talking about? And the main issue that people have been talking about is shifting the whole country's healthcare financing system from the current taxation-based or revenue-based healthcare financing to social health insurance. What does this mean? Okay, this would mean essentially collecting a payroll-based fee or a tax or a premium, whatever you call it, that would go then into a national health security fund to be used only for the reimbursement of specified healthcare expenditures. So that means,
Recording in progress.
okay, so this means that there will be a separate and autonomous source of financing for the health sector. And so advocates for SHI, or advocates for social health insurance, argue that this will then mean that the health sector do not have to compete with other sectors for central treasury funding. Okay. Furthermore, advocates for social health insurance argue that this health security fund will pay for both utilization in public facilities as well as private facilities, meaning that this common funding will allow the public and the private sectors to be more, quote unquote, integrated. So in this way, they feel that the gap in the remuneration between doctors in the private sector and the public sector can then be narrowed. So these are the two main arguments that has been put forth for social health insurance. And there is a very strong lobby, very strong pressure to move in this direction in the past several decades. So in response to this, I put forth two major points, two major arguments in the Malaysian context. That I argue that to achieve equitable healthcare system, number one, we have to retain the taxation-based healthcare financing system and not change to a social health insurance system. And the second point I will be arguing is that we must also keep a lookout on public healthcare provision. We have to protect and strengthen public healthcare provision. Okay, why do I say retain taxation-based financing and do not change to social health insurance? Basically, taxation-based financing has four distinct advantages compared to social health insurance. Number one, there is evidence that it is more efficient. How is it more efficient? So there is this World Bank study of OECD countries that found that countries that shifted over a span of 2 or 3 decades, there were countries that shifted in OECD that shifted from taxation-based to social health insurance. And then there were also some that shifted backwards from social health insurance to taxation-based system. Okay, so in the study of these countries, it was found that those that shifted from taxation-based to social health insurance, their healthcare expenditures increased without a concomitant improvement in health outcomes. Specifically, it was found that in these countries that shifted to social health insurance, per capita health spending increased by 3 to 4% across the board for the whole country, without any corresponding health improvements in health outcomes. Okay. Furthermore, for diseases that require strong population-based preventive health programs, such as breast cancer, for example. Breast cancer, you need a population-based secondary prevention program, like getting people to go for examinations, mammograms, etc., etc. Now, in that kind of case, mortality rates even became worse when they shifted to social health insurance. So this is the first advantage, more efficient. The second advantage that taxation-based has over social health insurance is that it is less expensive. Basically because when you have social health insurance, you need an additional layer of administration and management because you need to enroll people, you need to recruit, you need to collect premiums, and then you need to pay out benefits and you need to pay out claims, right? So this adds an additional layer of administration and management, which requires costs, so it's more expensive. Now, and this leads on to the third advantage that a taxation-based system has, which is long-term sustainability. if you look at insurance-based health financing, whether it's social health insurance or whether it's private health insurance, okay, in these kinds of health insurance financing system, there is a mechanism that puts an upward pressure on costs. There's always a pressure that costs will be pushed up. Why? Economists call it provider-induced demand. Demand for healthcare that is induced by providers themselves. Because in medicine, there's a lot of information asymmetry, right? Because when I go see a doctor, I trust my doctor. I believe that the doctor knows more than me about medicine. So when the doctor recommends further diagnosis, further treatment, further medication, I'm unlikely to not go along. I will, of course, want to protect my own health. And of course, I will go along with the doctor's recommendations for more services. So this sets up a mechanism for cost escalation. And this cost escalation, therefore, needs to be reined in, needs to be controlled by strong administrative controls and regulations in a social health insurance system. So this, in the long run, therefore, social health insurance will have this extra costs, and therefore taxation-based health financing in the long run will be more sustainable. Okay, what is the fourth distinct advantage? The fourth distinct advantage is the issue of risk pooling. Now, UHC, Universal Healthcare, calls for a type of prepaid financing method that pools risks across populations, okay? And this is important because when you pool the risk across population, there is cross-subsidization within society. So the healthy and those who are not ill, although they pay their insurance or they pay taxes, they do not use the healthcare services, but they subsidize those who are ill, who needs to use the services, okay? So both taxation-based financing and social health insurance are prepaid, and both have risk pooling, but taxation-based financing is advantageous because it pools risk across the whole population through the nation's taxation system that is already in place. For social health insurance, a separate collection system has to be set up. And this is normally payroll-based. There are two major problems with this payroll-based system. Number one, because it's payroll-based, it will usually be based on employee. It's like SOCSO or EPF, where employer will pay a certain percentage, employee will pay a certain percentage. In this kind of system, research has found that employers will tend to reduce their formal workers. They will tend to reduce their formal workers and casualize their workers in order to avoid paying social health insurance. And in another World Bank study in 2009, also in the OECD countries, this was actually shown that employers in countries which shifted to social health insurance, employers actually, the whole labor workforce was casualized by 8 to 10%. Okay, what is the second problem? That's the first problem. The second problem is the informal sector. Now, the government will pay for the poor, but those who are not poor, but in the informal sector, they have to cover themselves. So it is very difficult to collect from the informal sector. Okay, and it is for this reason that social health insurance is not suitable for low and medium income countries like Malaysia, which have very large informal economies compared to developed countries. Okay. Now, in this regard, the COVID-19 pandemic also provides a very important lesson. As a result of the pandemic, as we know, formal employment shrunk, right? So in any economic crisis, formal employment shrinks, unemployment increases. So in a social health insurance financing system, an economic crisis such as this pandemic will lead to decreased contributions. There will be decreased coverage with people falling through the cracks precisely at a time when they need healthcare. Not only that, people facing economic hardships will have to fall back on the public healthcare services, and as a result, the public health system will be further overstrained. All right, so this finishes my first point about the Malaysian context. The second point of my Malaysian context is about...
Dr. Chi, you have 2 minutes.
Okay.
To wrap up.
Right. It's about public provisioning. Now, so much attention is paid to financing that often we take our eyes off the issue of public provisioning of healthcare system. So there are many reasons how our public healthcare system can contract and deteriorate. As it is, when not enough money goes into it, it is already contracting, it is already deteriorating. And if we have social health insurance, it will contract and deteriorate further.
Recording in progress.
Again, I give you another lesson from COVID-19 pandemic. COVID-19 pandemic has essentially shown us how important the public healthcare services are in meeting new infectious diseases. The public had to depend on the public healthcare system for a quick and dedicated response, even in the early stages of the pandemic, when there was very little knowledge of how this disease is transmitted. Now, this kind of response depends very much on a well-integrated and coordinated public healthcare system. So the primary care has to be coordinated and integrated, supported by the hospital care and by the tertiary care. This cannot happen in the private healthcare system. As you know, private healthcare does not focus on preventive health services. There's no integration between primary care that is provided by the GPs and the care that is provided by private hospitals, right? And so I think that I don't have to stress for you all to see, because you all actually witnessed that it was our public healthcare system that rose to the challenge of meeting the difficulties and the problems of the pandemic, of the COVID-19 pandemic. So in conclusion, let me just say that we should note that healthcare is intensely political all over the world. Universal healthcare is intensely political. It is subject to interpretation. We have to give it our interpretation. Financial allocation to health sector is determined by politics. Changing healthcare system from taxation-based to social health insurance will not automatically lead to adequate financing. Whatever the system of healthcare financing, central treasury revenues will still be needed to cover the poor, the indigent, and infectious diseases, okay? And these allocations will still be subject to political will. At the end of the day, it will still be politics that determine whether the healthcare services cater to our needs. Thank you.
Thank you, Dr. Che. Indeed, it's worsening situation in Malaysia. I think the current healthcare system in many countries has been a race to the bottom. And of course, I agree that it is political, and the business and the capital are trying to take a benefit of this system by changing to the system that they want. All right. We will move to the third speaker, Gede. Gede, you have 20 minutes, and please speak slower.
I would like to share my screen.
Yes, you can share your screen.
Okay. Sorry. Okay. I would like to thank to the organizers for having me participate in this conference. I would like to bring a presentation to the socialist conference to how capitalist oligarchy undermines Indonesia public health and the risk of the hegemony. So the background, chronology of COVID-19 in Indonesia, that is since December 2019 to mid-February, the government of Indonesia still underestimate the seriousness of the pandemic. After the mid-February 2020, then the first case identified in Indonesia. But only on March 2, 2020, that the president of Indonesia officially announced that COVID has entered Indonesia. This brings the panic in the government in dealing with COVID, because the government respond to COVID, the pandemic, with the ad hoc politics, and the result is creating more panic in society because many working people have to stop their economic activity and the social activities. Now, in total, until August 2021, there are 4.25 million cases with 144,000 cases of death. This is of course more higher than the world average, which is only 2.08%. And the peak of the pandemic is in August 2021, where the numbers of weekly death in Indonesia around 8,784 cases, or more than 1,000 deaths per week. And also in the same month, this is quite interesting because the healing rates continue to increase, reaching 89%, exceeding the world average. This Indonesian high recovery and the victim rates are unusual situations. This is what I would like to highlight. Unusual situations. Logically, when the healing rate goes up, the death rate goes down, and vice versa. But why? What's happening? So the the state policy during COVID-19 crisis in Indonesia, responding to the coronavirus outbreak, like in many other countries, the government more rely on economic and security approach rather than public health. We can see it in Indonesia that there are 7 economic sectors during the pandemic crisis that actually showed annual growth in the third quarters. I show it as the 7 economic sectors. 2 tops of economic sectors, of course, health and social services, and also information and communication sectors. This is the 2 dominant economic sectors that showed annual growth significantly. This is, I would like to show the graphic of economic growth of Indonesia yearly and quarterly. One of the reasons for Indonesian economic growth in the second quarter of 2021 was the increased mobility of the people. I would like to stress the increased mobility of the people means that the working people still, especially for the working class, whether it's formal or informal, facing with the stress for the economic conditions, they also have to still looking for their livelihood. They have to fulfill their basic needs. So they have to find food, and support their family, so they have no choice other than go to work. And also parallel with the rise of household consumption growth with 5.93%. And the consumption of growth, the whole household consumption, the growth of household consumption, the highest is the health and social service sectors, and also the information communication sectors, mainly because the health and social service sectors is many of the working class in Indonesia, they have to show in every activity, whether it's travel or go to work, they have to show the testing results, whether they have exposed to COVID-19 or not. And the information communication sectors consumptions rise because many of the economic activities conducted at home, whether it's for school or for working from home. And also in the same quarter, the transportation and warehousing sectors also recorded the highest growth because these sectors is following the online economic sectors, like the shopping online, etc., etc. It is so the transportation and warehousing sectors help the important sectors. This is the pictures where I take these pictures in around June 5, 2021, where the mining workers in Sulawesi went to work, and also where they live and also when they return to home. The road is packed with the workers, so social distancing is impossible for the workers and also for the general working people in Indonesia. Parallel with political economic measures by Indonesian governments, there's also security measures. So the central government of Indonesia issuing orders to Indonesian National Police to help the process of decreasing the pandemic victim by deploying their officers to maintain social distancing. And also the enforcement of security approach in handling COVID-19 today is held with enforcement by issuing program of enforcement of emergency community active restrictions to the deep roles of the police, the military, and the National Intelligence Agency. So the contrast recorded that during the past year, for the period April 2020 to July 2021, at least 29 violent incidents. These incidents including many actions of the security forces, especially at the same time, and the Parliament of Indonesia, the Legislative of Indonesia, and also the central government of Indonesia issuing the Omnibus Law, which is well known in mass media that it was what I call responded by many working class sectors to protest. So the violence against working people is one of the impact the involvement of security forces in Paris field of handling the COVID-19 pandemic. Also, the police forces applied a security approach to handling crimes in cyberspace and ordering police officers to conduct a surveillance and patrol in cyberspace, or even They even block or hack the numbers of social media accounts accused of criticizing the policy of large-scale social restrictions and PPKM, and also arresting dozens of people who criticize that policy. But governments also know that they have a weak policy, panic policy. So dealing with the weak political consensus of the broad working population, the government of Indonesia also paid buzzers to propagate their support for economic and security policy. And these buzzers paid through the state budget. Did the implementation of political, economic, and security measures reduce the number of victims? Of course, the answer is no, because the rising numbers continue. But what is more interesting is the gap between the total case and the active case with the healing case and also the death case. The gap here is widening. This is what I call the area of unusual situations. So what it means by this gap, how we read the gap in this graphic. So how Indonesia privatized the pandemic. So the testing fee is paid by each person and not from the government budget, except for the state apparatuses. And we also experience the ambulance oxygen are not available enough for the rising numbers of victims of COVID, particularly during July and September 2021. And also, what more important is the ratio of population and hospital bed capacity is 1.21 compared to 1,000. It means that for the 160 million people in Indonesia, there are only about 310,000 hospital beds. It's below India. India has around around 2 or 3 compared to 1,000, and also below the China. So what I would like to show you is that the term of ownership of private hospital for profits, the growth is faster than government hospital, especially the private hospital for profits in the network of group hospitals. So for the 10 years, the government hospital only grew 39%, while the private hospital grew 92%. And furthermore, private hospital for profit increased rapidly, so that it controlled 67% of private hospital market. This is how the infrastructures, the healthcare infrastructures is being privatized and prepared to be privatized long before COVID-19. What will the above data strongly indicate? The pandemic crisis has become the means for elites in politics and business to further accumulate power and money. It is characterized by unwillingness of the government to deliver social security or social protections. That in Indonesia, the government only spend less than 1% of total GDP. It's below Vietnam, below many other Asian countries, and also characterized by relative absence of rule of law, by passing law, making democratic procedures in the name of emergency. Many of rule of law that has been issued is bypassed, and also it's opened up the pervasiveness of corruptions. I mean, then bypassing accountability in the name of emergency situation. And also the weakening role of anti-corruption commissions, and also in the government issue the government regulations that the state administrative court and government officials are immune from being criminally charged or not accountable of their actions and using public money. And also the oligarchy in Indonesia to run the government, manipulating political consent by paying buzzers, and also, of course, using the repressive state apparatus. This situation has made it possible for dominant oligarchic capitalist class to exploit the crisis instead of addressing it for the common good. So in times like this, many people, what is the meaning of privatized response to COVID-19 in Indonesia? So we are familiar with the quote unquote solidarity, social solidarity in time of crisis, but in times like this, many people turn to well-established system for emergency support, rapid assistance, recognizing the important role of communities, quote unquote, play in responding. It's also praised by international finance. This is the picture of how civil society in Indonesia open up the opportunity for those who want to participate to help other community handling the crisis experienced by people in Indonesia, from food and also from the red one is the campaign to ask people to ease the burden of a rent house. So anthropologically speaking, why are gotong royong or social solidarity and voluntarism at the nature of Indonesian society, or they are reaction to the particular political and economic conditions? So why social distancing is difficult to implement in Indonesia and of course in many other countries? I mean that of course the social cohesion or solidarity, I see that this is a reaction to the distinctive style of Indonesian government, which has so far been minimal in providing welfare system for its people, and consequently making people build their own social network action initiative. So in the era of neoliberalism, when the state act like a stingy father because they implement the free market principle by reducing subsidies on health, education, transportation, public, and implementing a system, communities at the lower level must be ready to subsidize each other. Reciprocity, working hand in hand to help each other between neighbors and family, is even more relevant to working people. So the goal of the lower classes to maintain friendships, care, and intimacy is to survive in the midst of cruelty of the free market competition. In the end, I have a proposed reflection for the socialist politics. I return to Gramsci meaning of crisis. I highlight the keywords that can be used for analyze and also used to open up discussion and also opportunities for socialist politics to more engage in the crisis that experience us, the working people. So it said that the gap that I have mentioned before is that the gap showing that the ruling class has lost its consensus. And the old is dying and the new cannot be born. And this interregnum, so this gap is with interregnum, this great priority, morbid symptoms appear. They should be highlighted by social politics because it is always important to recognize the morbid symptom itself, or the distinctive sign of death that characterize the interregnum within one order.
Good day.
Yeah.
Good day. You have 2 minutes to wrap.
Yeah. and another. Those symptoms signal a tear in fabric of values. So because those symptoms signal a tear in fabric values and belief, this is the opportunity of the working class and also their civil society organizations to be more active against the oligarchy in capitalist class. So with the focus on crisis, Gramsci formulation of hegemony can be read not only as generalized sociological fact, but also as an emphasis on the locus of struggle across civil society. So, but I mean, difference than the form of social solidarity I have mentioned before. The struggle in civil society politically should be parallel hand in hand with a political society. Why? Because in its general notion of the state, for example, Gramsci conceived the political society plus civil society or hegemony protected by armor of coercion in capitalist state. So I think without wider unification of private forces of civil society, the political apparatus, a state cannot guarantee its own role. Those forces can themselves be said to constitute element of the state or integral state. That's why Indonesian government pay buzzers in order to reinforce their policy and also their especially the class politics and also the power structures.
Thank you. Good day. Can you wrap up?
Yeah.
You're about to wrap up. Okay.
Yeah. So it is the rift that it was precisely the potential for this juncture between civil society and political society, not that harmony that motivated Gramsci. I think this is an important reflection that we should find a way how to develop not only universal healthcare, but also how the Marxists see the medical care. Thank you. Thank you, Fahmi.
Yes. Thank you, Gede, for your points. Very relevant indeed to our discussions. I now open the floor. There are several questions there in the chat box. First of all, the panelists, you can see the questions that have been raised in the Q&A chat box. And I will let participants who want to raise questions verbally. I see Dr. Kumar want to ask questions, and then please raise hand those who want to ask questions. I will give Dr. Kumar to, please.
Okay, thank you, Ami. My question is to Jofti. You're talking about how a socialist country would structure healthcare and how we follow Cuba. But until that time, until we become socialist countries, what does the left do? When the left is part of the opposition, when the left is small, what does the left do? Does it say, I only wait till we come into power and then I do something about healthcare, or do we do something now itself? Thanks.
Can I answer that, Sami?
Oh, okay, sorry. Dr. Kumar, you also have questions to Gede. You want to also ask that question?
No, that's okay, not so important. Just basically, I was asking whether, because Gede said that the case fatality rate in Indonesia is higher than the world average, 3% something compared to the world average. Question was whether it's because of underreporting, because total cases, I mean, deaths over total cases gives you the case fatality rate. So if you don't recognize the mild cases, not enough testing and all that, your denominator is smaller. So it may not be actually a higher rate, just that we're not diagnosing the milder cases. Just a comment, yeah. Thanks.
All right. Okay. Okay. Space for you, Jyoti, please.
Okay, thank you for that question, Comrade Kumar, and thank you, comrades. Well, I will just state very briefly the Philippine case because I did not touch much on the Philippine case because I wanted to dream with you, comrades, about a socialist healthcare. But in the Philippines, we just passed in 2019 the Universal Healthcare Law, which for the longest time, I think 2 years in a row, we did converse with civil society, mass movements, and organizations, both socialist and non-socialist people in the table. And because of that, we saw the progress of the universal healthcare law in the Philippines. And it is not perfect, I must say. But there are certain things in the universal healthcare law which I can be proud of. First is that we have claimed our space as a mass movement and civil society organization, that we were able to really debate on a universal healthcare law, not just for Filipino citizens, but for all of humanity, just like in Cuba. But of course, unfortunately, we did not win that round because we only have, according to the state, we only have very limited funds to accommodate even our 100 million Filipinos in the Philippines. Second, we were able to push for a guaranteed permanent employment with competitive salaries under the universal healthcare law, and that is one thing that we should be claiming space about. So if this a campaign of Ka Walden and Ka Liodi in the Philippines, they should be taking this up and really fighting for a guaranteed permanent employment for health workers. And another thing that we really discussed also, which fortunately for Malaysia, they have a taxation-based type of financing for universal healthcare, which the Philippines do not have. And we fought for that. But unfortunately, we still have a social health insurance which treats health per disease, per organ. So we wanted a type of health service wherein it will cover essential health services. So I think, comrades, we have to really fight and not be a contributory factor to the defeatist attitude of these people around us, because there are a lot of defeatist people here. Even socialist Democrats are here. So that's the reason why I also do not want to spend time discussing on rights-based approach, because this is an accommodation in the earlier days, and you know that. So I wanted to fight for a collective type of rights, which is public health for the Philippines, and of course for the region and for the world. So I think what we need to do is really be to struggle. It's an ideological struggle and a battle, and we should continue that. Thank you so much. That's all. I hope I answered the question.
Yes, thank you, Jofti. We have several questions on Q&A chat box. Some have been also responded by the panelists. And then in the meantime, if everyone want to have questions, you can raise your hand. You can ask verbally. There are several questions. Of course, also comments by Thai Yuki about the situation in Thailand. Certainly, it is also related to the political situations. No matter what, the healthcare system is also, something that is fought, and business authorities are also trying to take a benefits of that. All right, Dr. Chi and Jofti and Gede, you want to respond to the questions that emerge in the chat box? Probably Dr. Chi, your space.
Thank you. I'm still trying to read the chat box. I'm sorry, I'm not very good at multitasking. It's a function of old age, I think. But anyway, I was reading one of the questions, and one of the questions was about why why Malaysian government doesn't come out with its own public what is it? Public health insurance is cheaper and affordable universal medical insurance scheme. Actually, I have been arguing in my talk that we should fight for taxation-based healthcare, where services are provided almost free or almost free at the point of utilization. So in this kind of system, anybody who walks into a healthcare service, a public healthcare service, should be given healthcare, adequate healthcare, right? So you don't really need medical insurance. So so it's not a system like America. American system is dominated by private health insurance, and therefore the government provides Medicare and Medicaid, and now under the Affordable Care Act, it provides certain sectors of the population to be able to buy to receive, or larger sections of the population to be able to receive I think it's Medicaid, not Medicare, right? So it's two different systems you're talking about. So in this kind of taxation-based system, there is no there's no reason for the government to provide public medical insurance, because you don't really need it. I think that was the question. Am I right? Have I answered the question?
Yeah. Yes, that's somehow response to some questions. The others is the other question from Robert. Robert question was regarding the model, and then with no decent living wage and wage suppressions in Malaysia, is it possible to introduce social health insurance in the country? Is it possible the model that you propose to be implemented in Malaysia? That's the question from Robert. What do you think?
Is it possible to implement social health insurance? Is it?
Yes, introduce social health insurance in Malaysia.
But I just explained that we would like to fight for taxation-based healthcare. It means the government will pay and support and provide, as well as finance, healthcare, public healthcare for those who need it. So we don't need social health insurance. Social health insurance, you have to be an enrollee. You have to enroll to be a recipient of social health insurance, right? And there are a lot of criteria, a lot of conditions. You have to follow these conditions, and then you have to pay. You have to pay a premium to before you can get healthcare. So we are saying that taxation-based healthcare system is better because it provides freely healthcare free of charge at the point of use to everybody. And we are saying that it should be provided to all residents, in fact, and not just the citizens as it is now, at the point of use. So you can walk in, and if you need to use the healthcare, you will be provided with healthcare. So you don't need to fill in a form to say that you had already paid this insurance, and then you don't have to go and claim that this is my claim for this procedure, that I have this illness, I was diagnosed with this, and therefore I need this treatment, and this is the proof, and therefore based on this proof, then can you please reimburse me for my what I have already paid for my healthcare. That's a very complicated system, isn't it? I mean, compared to a taxation-based system, it's very simple, right?
Correct, indeed, yes. The other question is for Gede.
Yeah,
There's a question, is it possible that, where is
Yeah. Yeah.
Can you see the questions for you in the chat box?
Yeah, of course.
Yes.
Yeah, I have answered the question from in the chat box from Luis, and so I would like to answer the question from Kumar. Yeah, same answer that from the point of view, epidemiological point of view, the low mortality rates is the higher case of fatality rate. Sorry.
Okay. All right.
Is it possible that the higher case fatality rate seen in Indonesia is because many of the less serious case? Yeah. Also, the other case, such particularly for the comorbid disease, even the comorbid disease that accompany COVID-19 can be claimed as a result of COVID virus. So the higher the case, the higher case of fatality rate is also influenced by the comorbid factors. Because yeah, from epidemiological point of view, the low mortality rates, even the compared to populations, the low mortality rate is partly due to the absence of data on the causes of death. So we haven't any clear data the causes of death, except related to COVID. Autopsies on victims are rarely performed. So even the comorbid disease that accompany COVID-19 can be claimed as a result of COVID virus. So the low, I think that the low numbers compared to the population 260 millions is also influenced by the political factor of decentralization, where the regional heads do not want the number of the deaths to be associated with COVID-19 and affect investment and regional economic growth. So, but I would also like to add that we have to look at the history of the medical history, especially in the Marxist view, because the first major Marxist view of healthcare was in Engels, was published by Engels, The Condition of the Working Class. But Engels' treatment of the healthcare problems, medical care and disease was to have a profound effect on the emergence of social medicines in Western Europe, particularly in the work of Rudolf Virchow. We should see this history of Marxism and also disease and medical care. So Virchow's pioneering studies in infectious disease, epidemiology, and social medicines is influenced by Engels' works. Virchow himself acknowledged Engels' influence of his thought. What he would like to show is that Virchow recommends a series of profound economic, political, and social changes that include increased employment, better wages, local autonomy in government, agricultural cooperative, and more progressive taxation structures. So Virchow advocates no strictly medical solutions such as more clinic or hospital. Instead, he saw the origins of ill health in societal problems. So the social insurance, social protection schemes is only a small part of the whole Marxist perspective on medical care. So the most reasonable approach to the problem of epidemics then was to change the conditions that permit them to occur. So during the period, Virchow was committed to combining his medical work with political activities. So in 1849, he joined the first major working class revolt in Berlin. And during the same year, he strongly supported the short-lived revolutionary efforts in Paris Commune. I mean that his scientific investigation and his political practice, Virchow expresses two overriding themes. First, the origin of disease is multifactorial, is different than the modern medicines that unifactorial. Among the most important factors in causation are the material conditions of people's everyday life, including the ecological crisis. Two, an effective healthcare system cannot limit itself to treating the pathophysiologic disturbances of individual patients. Instead, to be successful, improvement in the healthcare system must coincide with fundamental economic, political, and societal change. That's what I would like to ask to remind. We should look at the history of a Marxist perspective on disease and also social care. Thank you, Fahmi.
Thank you, Gede. People can raise hand to us directly to the panelists. But in the meantime, maybe while we are waiting for questions from the panelists, maybe any speaker, Jofti or Dr. Chi, also can add to the insights from Thai Yuki. Thai Yuki share the situation in Thailand. The idea was that no matter what, we are fighting for the healthcare system, but as long as the political system is controlled by the liberal and those who are controlling the political system and the states, so the healthcare system that we are fighting will be nonsense. So would you comment on that, Jofti?
Yeah, Fahmi, thank you for that. Yes, I actually definitely agree with Gide's point a while ago. We cannot just look into the direct health issues and solve it on its own. We need to also, as I've said a while ago, we need to be transdisciplinary in our approaches. We look for places or instances or even areas where we can really claim spaces and provide inputs on, for example, in transportation, in the economic system. Like, for example, we discussed about Cuba as a working model as of the moment, but we cannot just copy paste Cuba in each of our countries, because in the first place they have this socialist agenda. Well, in the Philippines, for example, we do not have that. We have a backward capitalist system. In fact, it's not even like those of the first world kind of capitalism. So definitely we have to continue our struggle on that one. And the health activists like ourselves need to be in all spaces at all times. Like, for example, in the discussions in federalism, or discussions in, like I mentioned, transportation, or in social inclusion, we need to be a part of those discussions. In fact, we have to push that our economic managers be replaced, or that segment of the country's, the coordinating council, wherein all our economic managers, we need to field in other experts and even civil society or mass movement representation in that area, because these are the areas where where the decisions happen. How we create industrialism, how we pursue industrialization, how do we prioritize. The Philippines always prioritizes debt. It always prioritizes foreign direct investment. And so we say, why not we develop our own local domestic pharmaceutical industry, or manufacturing of our own PPEs, protective equipment during pandemics. Why can we not do that instead of importing these things? So socialists and activists alike should be in that same room with them and discuss and debate all the time with them. So we cannot just stop and be defeated by the idea that all are authoritarian. So we fight. That's the only answer, I think.
Right. Yeah. Dr. Chi, yes, we very much agree with the proposal that the universal health system should be, at the moment based on the taxation rather than the premium. That's very much also in the context in other countries like in Indonesia. And yes, you mentioned also this is a political, very much political. So our question is, how political is the healthcare system you are fighting in Malaysia, in Malaysian context? How political is that?
When I say it's political, what I mean is that ultimately it's political. So in that sense, I agree with what Tai Yuki has written. Ultimately, it is political. But the political struggle or the class struggle also occurs in the health sector. So the question is, what do you do in terms of actual real world actions that you can do before you have your final revolution and set up a socialist state, which is not really on the horizon at the moment, correct? So so we are addressing questions that are more immediate, right? So more immediate meaning that there is a pressure, there is a real pressure to shift to social health insurance in a large way. If you want to go with some analysis that I've seen, social health, universal healthcare (UHC) compared to PHC is a shift towards more neoliberal ideas. How is it not more neoliberal? It's more neoliberal because they are separating. They're separating financing and provision. So even though financing is public, social health insurance is public, you are talking in terms of providing a big source of public funds that can also be used in the private sector. So this is very, very attractive to the private sector because, you have like almost, you don't have to squeeze your customer one by one, because your customer comes and they have guaranteed financing, correct? So social health insurance is very attractive to the private sector. And in some low-medium countries, they have been pushed in the direction of social health insurance. Okay, now if you are in a situation where you can go either way, you can also be pushed in the direction of taxation base, right? You can also be pushed in the direction of social health insurance if you are in a situation where you have nothing. Okay, but if you already have a taxation based system, why do you want to allow yourself to be pushed into social health insurance? But of course, if you have a system where you have only private health insurance, then it makes sense to push to go into social health insurance, because then social health insurance is more progressive than private health insurance, correct? So it depends on the context. It depends on where you are situated, And then when I read what Tai Yuki has written, actually Thailand has a very good healthcare system, very good public healthcare system. And you have to give credit to the student activists of the 1970s who went into medical school. Some of them went into the jungle, came out back again, went into medical school, and they served in the public healthcare services. And they are responsible, I think, for much of the public healthcare infrastructure that has been built in Thailand. And it is for this reason that Thailand has a very reasonable response to the pandemic compared to some other countries, compared even to America, United States of America. I think Thailand did very well. Okay, let me just stop there.
Okay, thank you. We have another question from Angelo Miguel in the chat box for any of you, the speakers. But Angelo bring us Philippines context. But this situation in the Philippines can also be, the situation in Indonesia as well, or in Malaysia. So Angela's question is, in the Philippines, there is a community pantry phenomenon that began last year as a response to the need of those in urban and rural communities that was decentralized but interconnected between municipalities. Is there a possibility that a similar kind of model or structure for local healthcare to fill in the gaps of the public and civil sector where the current system remain insufficient? Hope you get that. Maybe we start with Gede. Maybe Gede, you observe the similar situation happening in Indonesia in response to the COVID. And then after Gede, we can ask Jofti, and afterward, Dr. Chi. Or Gede?
Jofti first.
Yeah.
Yeah. I propose Jofti first, then I would like to respond.
Okay. Jofti, you are privileged to answer first. Okay. Can you start, Jofti, and then afterward, Gede, and then Dr. Chi?
Yeah, I think they mentioned about the community pantries in the Philippines, and they're asking about the several alternative structures. For the community pantries in the Philippines, it's good that it's a feel-good initiative. We welcome it because it came from, the young ones who are involved in the community pantries. But we have to also be factual about it. It is not socialism. It will always be limited because of the resources are based on voluntary donations and volunteers who organize and does the sharing of goods and vegetables to each community pantry. So it sparked inspiration, but again, we have to be realistic about it. And, we always strive to push the state to do these things in a large scale. For alternative structures, we currently have in government referral systems, or before it was known as the interlocal health zones. These are local health zones that are somehow decentralized, but trying to be cohesive in a manner that it provides services to the people. But with the universal healthcare law, it is now being replaced by what we call the local health networks, or the primary care team. So it has evolved into a lot of names, but it is trying to re-centralize, but not so. Re-centralized in a regional level or subnational level, wherein several facilities and teams can be coordinated, so that the patient, when he or she enters the system, the health system, he or she will be navigated by these community teams, these local health networks. And then the focus will be primary care and not a specialist type of health services. And we support this as well. And they will also form a special health fund, wherein some of the funds that will be coming from the national will be inputted or collected in that special health fund. Now, the problem lies where if the local chief executive, or what we call the mayors and the governors, are not will not prioritize health, because they will prioritize other things. So that's where we come in to advocate for health services at the local level, and look into also the determinants, as what Gede has been mentioning, the importance of socio-economic factors and culture within the system. But of course, we do not forget as well the traditional healing practices that has been always here. It has been my advocacy to always recognize these healing practices, because evidence-based medicine has been used by the neoliberals to thwart or not to isolate communities, isolate these healing practices and healers in the community. So as much as what we advocate for actually is to include them, integrate them in the system, as what WHO has been also calling all countries to integrate traditional medicine and complementary medicine into the healthcare delivery system. And we are doing that in the Philippines as well. But of course, there's a lot of improvement that needs to be done, because at this present time, it is more or less a parallel type of health system, wherein there is the modern medicine and then there is the traditional medicine separately working, not working together. So those are some of the examples of alternative structures that are now in the Philippines. Thank you.
Thank you, Jofti. Good day. You have 2 minutes, and then Dr. Chi.
I would like to back to the history of the medicines in order to answer the question from T. So why did the unifactorial perspective of germ theory achieve such prominence in the germ theory? I mean that why this pandemic is caused only by, many people perceive that this pandemic is caused only by viruses or other pandemic only by viruses. Why did unifactorial perspective of that germ theory achieve such prominence? And why have the investigational techniques that assume specific etiology and therapy retained an early mythic characters in medical science and practice to present day? So a serious historical re-examination of early 20th century medical science, which attempt to answer this question, of course, has begun only in the past few years. Some preliminary explanation have emerged, and they focus even led and follow with publication by Flexus report. It's a coincidence with what Jofti has already mentioned. The Flexner report has been held in high esteem as the document that helped change modern medicine from quackery to responsible practice. One underlying assumption of the report was laboratory-based scientific medicines, oriented especially to the concept and methods of European bacteriology, produce a higher quality and more effective medical practice. Of course, although the comparative effectiveness of various medical traditions, including homeopathy, traditional folk healing, chiropractic, and so forth, had never been subjected to systematic tests, the report argued that medical schools not oriented to scientific medicines fostered mistreatment of the public. So the report even called the closure of or restructuring the schools that were not equipped with teach laboratory-based medicines. This is why the traditional medicine has no place in the modern capitalistic medicines industry or systems. So the report repercussions were swift and dramatic. Scientific, laboratory-based medicine became the norm for medical education, practice, research, and analysis. So recent historical studies cast doubt on assumptions in the Flexner report that have comprised the widely accepted dogma for the past half century. They also document the uncritical support that reports recommendations received from parts of the medical professions and the large private philanthropies. At least partly because of these events, the Marxist orientations in medical care remain in eclipse. So I mean that, of course, the people initiative is important, but only if they connected with the Marxist movement and also with the political organizations that drove the Marxist movement into the political arena in the state in order to compete with the capitalist modern medicines style. Right. Yeah, thank you.
Thank you, Gede. Dr. Chi, while you may address that points, I want to bring other questions, but something related to the previous question about health tourism. You also addressed that, responded that question on Q&A. But the question from Matafi here is that, what do you think of health tourism? What is your perspective? Because although it enables domestic revenue for developing countries like Malaysia or Thailand, but it caused great brain drain of specialists who left the government hospitals, public hospitals, to get more income. So what is your perspective on that?
Okay, let me just narrow it down to medical tourism rather than health tourism, because health tourism sometimes refers to spas and other things as well.
Okay.
In medical tourism, actually the literature has developed quite a bit in the last 20, 30 years. So in the beginning, there was a lot of hype about medical tourism because of the development, the very rapid development of the medical tourist industry. In Asia, it was sparked or triggered by the 1997 Asian financial crisis. When the Asian financial crisis happened, the private hospitals lost a lot of their clientele within a particular country. So what happened was they looked abroad for new clients, for new patients. And so they tried to market themselves abroad, and then they created this industry and this tourism that generated demand for their services from another country into that cross borders to use healthcare. Okay, actually the literature now shows that this kind of medical tourism is actually something that is very prominent in the media, but actually the mass amount of tourism, the really large medical travel that happens, actually only happens across neighboring countries. Okay, because it's not very convenient, right, to travel for healthcare from one corner of the world to the other corner of the world. So actually it happens between neighboring countries, number one. Number two, it happens when you have a migrant population that has migrated to a country, like Mexicans who migrated to America. Then they don't have very good access to healthcare in America. They go back to Mexico for help, for using healthcare. Now, neighboring countries, one is like Malaysia and Indonesia. It's like Myanmar and Thailand. Okay, so there's people who cross the border from Laos or from Cambodia to use health services in Thailand, because Thailand has better health services and their own country don't have, all right? And in Indonesia, it is a failure of the medical profession to a large extent, I think, and the government, because there is a lack of trust, I think, a lot of lack of trust that allow for this generation of demand to go across the border. So the best way to solve this problem is actually to provide good medical health care within your own country. And I think that there should be regional cooperation in this. Okay, there should be, if we see ourselves as public versus private interests, right? Corporate interests versus people's interests, then governments of the people should work with each other to help build up healthcare systems in their countries for the people, right? You don't see yourself as being Malaysian versus Indonesian, but building public system with regional cooperation, helping each other build your healthcare system, so that the development of healthcare system is not so uneven across countries. I think that is the problem, the basic problem that has to be addressed.
Thank you, Dr. Chi. Comrades, times is up. I'll ask panelists to have a closing remark, 1 minute each, or less. Well, let's start with Jofti. Jofti, maybe half minutes, Jofti. Everyone, half minutes.
Yeah, thank you, Fami, and thank you to all the speakers and the comrades here in the room. Thank you also for inviting me to the Socialism conference. What I only have to say is let's continue to fight for a socialist healthcare. I know it would be hard given all the limitations, but we need to continue the struggle, the ideological struggle from within our countries. And of course, push for comprehensive policies, like for example in the Philippines, the national industrialization policy, in order to give jobs to every one of us, so that we may also be so we can live healthily. We have the enabling environment to do so. So then let's move forward towards socialism, comrades. Thank you and good afternoon.
Thank you, Jofti. Good day. Half minutes. Good day.
Yeah, I just would like to thank you for inviting me to this invaluable meeting of comrades. Hope you are always healthy and we can meet again in the next opportunities. That would be all, Fahmi.
Thank you. Good day. Okay. Dr. Chi, half minutes.
Thank you, Fahmi. I think that all I want to say is that recognizing that you want to struggle for a socialist society. Nevertheless, we have to recognize also that we live in a capitalist system. So the question is, within this capitalist system, how do we progress, right, towards a more socialistic kind of system? So in this regard, there is, I think, I think that the people's health movement or people's movements have no choice but to pressurize governments, to make demands on government, to have pressures based, to pressurize governments to really realize the people's needs. Because you cannot pressurize the private sector in a capitalist system. Okay, the private sector is not here to recognize you, not here to benefit, to do charity, right? So the only way is to make demands and to pressurize the government. I think that is the way.
Thank you, Dr. Chi. Comrades, time is over. I would like to thank the speakers. Thank you, speakers, for insightful points you make. There are many takeaways from our discussions, indeed. The closing remark, the closing statements, indeed very well said. I leave it to all of you to take the conclusions. And thank you again, and we will see you in the next sessions. Thank you and good afternoon, good evening.